Let me move to the seventh session for clinical-based nephropathological session, and we will begin with Professor Iman Sarhan for IgA Nephropathy Recent Advanced and Prospects. She is Professor of Internal Medicine and Nephrology, Ain al-Shams University, Cairo. And Professor Iman's main interest and experience in critical care nephrology, hemodialysis, PD, and diabetic kidney disease. And she had many publications.
Thank you for your kind introduction, and I was so happy to be invited in the first Oman conference. We'll start by the history of IgA nephropathy, which is the most common primary glomerulonephritis worldwide. It's present or presented or mainly defined by Dr. Jan Berger, and it's called Berger disease in 1968. This is a common age for this disease, about from 20 to 30 years. The global distribution of IgA nephropathy, mainly in East of Asia, Japan, China, Singapore, and then Arabian country as a Caucasian, less incidence, and in United States, and in Africa is a little bit lower. The clinical presentation is too much different, maybe coming from the bottom of iceberg, which is just IgA deposition in the glomeruli without any clinical symptoms, may be presented with a symptom like hematuria, proteinuria, or even in the stage and rapidly progressive glomerular disease. And the commonly is called macroscopic hematuria in 40 to 50% of cases. And this usually accompanied upper GI, upper respiratory tract infection or GIT infection. Sometimes non-visible hematuria in 30 to 40% of patients. Sometimes presented by nephrotic syndrome. In less than 5% of patients may be presented with acute kidney injury, rapidly progressive glomerulonephritis disease, hypertension, or CKD. The main diagnosis for this IgA nephropathy is the kidney biopsy, actually. Usually mesangial hypercellularity, maybe focal and segmental, or maybe diffuse and global. Also, focal glomerulosclerosis and tubular affection, and maybe presented by crescent. The important dominant finding in IgA nephropathy is the dominant IgA in immunofluorescent. This is must be present maybe in 100% of cases, and other immunoglobulin is present but lower percent. Electron microscopy, just immune deposition present in mesangium and paramesangium, but has no structure. Oxford classified the IgA nephropathy in 2009 by presence of mesangial hypercellularity, endocapillary hypercellularity, segmental glomerulosclerosis, and tubular atrophy. And these four called the MIST score, and they a predictor for decline in estimated GFR. Recently, maybe in 2016, Oxford update the classification and add crescent as an independent prognostic factor also. This is Oxford classification, just we call mesangial hypercellularity as present. So it's M1, not present, or less than 50%, it will be MO. Endocapillary present hypercellularity, either E, O, or E1. And also segmental sclerosis, either present S1, not present SO, and tubular interstitial disorder 0 when less than 25, from 26 to 50 T1, and more than 50 T2. Crescent not present CO, and C1 less than 25%, and more than that is C2. This is example for the M1 E0, S0TO. This is just mild to moderate mesangial proliferation. And this is another example for the severe increased mesangial matrix, and also there is endocapillary hypercellularity, and there is focal segmental glomerulosclerosis and some tubular effect. So I think this will be M1, E1, S1, and T1. The pathogenesis of IgA is a lot of discussion in it, but just I want to summarize by people who are genetically predisposed. People who are genetically predisposed, and when they have an environmental factor like upper respiratory tract infection or gastrointestinal infection, they will perform abnormal IgA. This abnormal IgA called deglycosylated IgA. This is the deglycosylated IgA coming from the plasma cell, but the plasma cell present apparent IgA called Gd-IgA1. Gd-IgA1, the problem is only in the hinge. There is lack of glycosylation. This will initiate an immune system, and this will cause IgG against this hinge for IgA1. And this will initiate an immune complex, and this immune complex will be deposited in the mesangium and cause activation of the complement and cause the full-blown picture of the disease with hematuria and proteinuria. Another theory is called the gut-axe theory in IgA nephropathy. Either there is a food nutrient like gluten, like some proteins. This sometimes another problem, which is the gut-axe, the gut dysbiosis. When the parity of the GIT is broken and already lead to some of organism will come into the lumen and initiate an immune system. Both these will make as an antigen, and they directly affect the mesangial cell, directly affect the mesangial cell as a effector cell, which cause initiation of the immune complex and deposition and cytokines and initiation of the disease. It can be occur in chronic liver disease, and autopsy shows that most of liver disease has IgA deposition because of less clearance. Can be occur with HIV, but I think the autopsy calls that it is not so common, between 0 and 8. Inflammatory bowel disease is present with it, associated with other glomerular disease like minimally changed disease. Others like dermatitis, herpetiform, seronegative arthritis, lymphoma, small cell carcinoma, and disseminated tuberculosis. This is the secondary cause. Clinically, what is the outcome for this? Usually on a clinical base, we have a presence of hypertension is a risk factor. GFR reduced. GFR is a second risk factor, and the degree of proteinuria is a third risk factor beside the MIST-C score. And we have already 80% renal survival over 10 years, and over 20 years, 25 to 50% of the patient go to end-stage kidney disease, and 30% recurrence in transplant. Another calculation for the deterioration of the kidney function is by international IgA predication tool, which is present online, can be a mobile present. You will add only the estimated GFR, the systolic and diastolic blood pressure, proteinuria in grams, and age of the patient, race of the patient, and use of ACE or ARBs, or use of prior immunosuppression, and the classification, X42 classification MIST-C score. And the result will be like this: the 50% decline in estimated GFR and progression to end-stage renal disease will be a number according to the data you entered. So this will be a prediction for the outcome for IgA nephropathy. But actually, till now, we have no uniform consensus of the threshold upon which we consider this patient is dangerous or not. So still, we are discussing the patient about the result, and we will try to start management. What is the management aim? I think there is no curative treatment for IgA, so just the aim of our treatment just to prevent the progression to end-stage renal disease, and this clinically by improvement of the urinary sediment and reduction of proteinuria to be less than 1 gram and preferred or better, if you can, to reach less than 0.5 gram. Better to be through supportive care than immunosuppression unless there is IgA variant. According to Kuduki guidelines, they assess the risk for this patient, assessing the presence of proteinuria, hypertension, SMH-GFR, and already do renal biopsy and do Oxford classification, and then we categorize the patient either high-risk patient when there is proteinuria more than 1 gram and active proliferative phase, so M1, E1, and maybe C. This is already make proliferative change, so we will be aggressive in treatment for this patient. In contrast, if there is T or S, so this is a chronic lesion, so we can continue on just supportive treatment only. The rule is please don't start immunosuppression if the patient has SMH-GFR below 30, and a combination of immunosuppression is not allowed except only rapid progressive GN. If the patient has only recurrent visible hematuria or just proteinuria less than 0.5, only non-specific treatment for this patient. If proteinuria more than 0.5, so we will start supportive care, and supportive care we need lifestyle modification, weight loss, smoking cessation, healthy diet, decrease sodium intake, and promote exercise. The second is the control of blood pressure, which is a target for 130/80 till 125/75 in a proteinuric patient. This is first choice ACE or ARBs. Address cardiovascular disease, and ACE or ARBs can be even given in patient with normal tension, normal blood pressure, because this is the most important line of treatment, and it must be given in maximal approval or maximal tolerated dose for those patients. I think nowadays SGLT2 inhibitor can be used in a selected case, and from DAPA-CKD, we have already 270 patients with IgA nephropathy, 6% of the population in this, and they already found that the primary composite endpoint decreased by 71%, which is very high as regard the prevention. So FDA approved already the SGLT2 inhibitor for treatment of CKD maybe after this study. Empakidney also, I think, has beneficial effect despite diabetes or non-diabetes, despite the level of SMH-GFR, and when proteinuria more than 30, albuminuria more than 30, so they have beneficial effect to decrease the progression to end-stage renal disease. And I think in 2023, Kuduki guideline approved SGLT inhibitor in treatment of CKD patient, even with no diabetes. A newer for supportive care is sparse. This drug can be used in IgA nephropathy, and it is a dual angiotensin II inhibitor plus endothelin 1 receptor inhibitor. Efficacy and safety will tested, and over 400 adults will be approved after of kidney biopsy by IgA nephropathy, were allocated to sparsentan or irbesartan. And we found that decrease of proteinuria is more than 49% compared to 15% in irbesartan, with relative risk reduction of 41. And this, I think, makes that the sparsentan have a conditioned approval by FDA, waiting for the rest of the study, and this is the next study will be. Kuduki guideline advise, but only suggestion for the fish oil if the patient has proteinuria more than 1 gram and is on treatment for supportive care for more than 6 months. Tonsils play an important role in pathogenesis, but actually tonsillectomy does not reduce the risk of developing renal failure or progression of IgA nephropathy. After 3 months, we will evaluate the patient again, high-risk patient, if proteinuria more than 1 gram, so we'll start immunosuppressive treatment. If lower risk, so we can continue or optimize the supportive care. For more than 1 gram proteinuria, we'll start 6 months dose of corticosteroid. For IgA variant, I have another problem. If the patient has acute kidney injury, we'll manage to add supportive treatment for acute kidney injury. If rapidly progressive glomerular disease, so we'll be given the cyclophosphamide plus corticosteroid as induction, and then we will maintain on steroids plus azathioprine. Sometimes a patient with IgA has associated with minimally changed disease will start by treatment for corticosteroids 0.5 to 1 milligram for less than 8 weeks. We have a debate in glucocorticoid and IgA nephropathy. Actually, Kuduki support the use of glucocorticoid in patients with high-risk patient, and still, till now, clinical benefit of glucocorticoid in IgA nephropathy not yet established, and we need to use it with complete caution because we have GFR below than 30 if the patient is obese, if he has diabetes, if he has osteoporosis, so we need to take care of this, and we will ask ourselves, what is the next, what is the alternative for this? This is a study for the corticosteroids, and here they use 500 patients allocated for methylprednisolone, the dose 0.6 to 0.8, and they found that the primary endpoint by decrease the GFR by 40% is improved, and also the secondary endpoint for kidney failure decreased, and also the progression to end-stage renal disease and 50% decline, and estimated GFR decreased by 50%, and the risk for mortality decreased. This is a new study in 2022. This is called testing trial, and there is a lot of testing before. Another study called Stop IgA. This is a study monitoring the patient for 10 years, for patient for supportive treatment and patient on corticosteroid, and they found there is no difference by adding the corticosteroid on the maximal supportive treatment. So this is another but negative study. This is a testing study, but it occurred in 2017. They found no doubt that the steroids will help the renal outcome, end-stage kidney disease, or drop of estimated GFR, or even proteinuria, but the cost is high. So we have a serious side effect, and infection occur in 13 versus 0, and serious adverse effect 28 versus 4. And this obligates the author for this study to stop early this study because of side effect. What is alternative for this? We have a problem. We have cyclophosphamide and azathioprine. It's also limited to patients with rapidly progressive glomerular disease if they are due to IgA. Rituximab failed to show a response in IgA nephropathy, but actually it has a role in IgA nephropathy with vasculitis. We have another drugs like MMF and CNI. We'll just see in 2023 we have a study on 170 patients allocated to either placebo, which is a supportive care, and MMF, and they found these patients that have a lower progression to end-stage renal disease, and this is significant, and also lower proteinuria. And the post-trial follow-up, they found that the patient who chose to discontinue the MMF has accelerated loss of the kidney function. And I think so this change the brain for the authors, and Kiduki, I think, don't support the use of MMF in IgA nephropathy, but after this study, I think it's become a preferred alternative methods for IgA. Leflunomide can be used, and they found that the use of leflunomide with low-dose steroid, half-dose steroid, cause remission is better than steroids alone. And also another study on the meta-analysis on leflunomide with corticosteroids. This is meta-analysis concluded that corticosteroid with leflunomide is more effective than corticosteroid alone. And this may be another option for us. What is the new options for IgA nephropathy? Here, I think that we have another. It's okay. I have. Okay. The first, I have a targeted release formulation, bedinoside. This is a new formulation of the corticosteroid. The aim of this formulation is to open N-terminal ileum, where the Bayer patch is present, where is more lymphocyte is present, and modulate the effect of lymphocyte in this area. This study for this. And second is hydrochloroquine, which is an immune modulator for toll-like receptor. And the third is inhibition of the already proliferation of beta cell by BAFF-APRIL signal inhibitor, and maybe another head for immune complex, so anti-complement can be used for this.
Iman, just 1 minute.
Okay, I will finish. Only 1 minute. So this study targeted release corticosteroids. They found that they have excellent result for decrease of proteinuria and stabilization of the GFR, despite the placebo increase the proteinuria, but actually they found a lot of side effect. This is another study on targeted release, and they found that 9 months use of this formula decreased the proteinuria by 27% in 6 months and 48% in 12 months, and also stabilize the GFR. I think maybe this is promising, and this FDA approved, but also condition approval till the finishing of the study. Hydrochloroquine found to be decrease the proteinuria over a range of estimated GFR. And this is the newer investigational drugs, and already it's ongoing and waiting for its result for complement and for BAFF inhibitors. And finally, what about the gut axis syndrome intervention? Sometimes they found that if we give low antigenic diet, low gluten diet, they may found that they change the IgA deposition in the kidney. And another thing, the presence of reduced short-chain fatty acids. Short-chain fatty acids in the gut mean that there is the predilection of some microbiota. So they found it lower in patients with IgA nephropathy compared to the control. And also the use of some antibiotic polymyxin will decrease the IgA, but this is on animal study. We need to monitor our patient for every 2 to 3 months, maybe monthly if I have immunosuppression, and monitoring as usual serum creatinine, urine analysis for active lesion, and urinary protein creatinine ratio. And actually, finally, I just want to know that IgA is the commonest glomerular disease worldwide. There is apparent IgA1 in genetically predisposed patient initiate an immune complex and complement activation and causing the disease. Macroscopic and microscopic hematuria plus or minus proteinuria is a common presentation. Extrovert classification called the MIST, and on 2016 MIST-C for evaluation, and also IgA, International IgA scoring tool. Treatment by corticosteroid in a patient with risk patient with proteinuria more than 1 gram. And supportive medicine is a very important fee and the main core of treatment for this patient. After steroids, we have some alternative like MMF, CNI can be used. Leflunomide can be used for this patient with decreasing proteinuria. Hydrochloroquine and targeted release formula for corticosteroids is maybe helpful. We are waiting for the newer investigation or newer drug to help us in treatment of IgA nephropathy. And thank you.
Talk. The next session will be a joint session actually by two of our pathology colleagues, Dr. Marwa Riyami and Dr. Sajed Tamimi. Marwa is an anatomical pathologist with particular interest in renal pathology, and she's in the Sultan Qaboos University Hospital and a member of many committees and program director for anatomical pathology. She'll speak first. Thank you very much.
Thank you very much for the kind introduction,
Yes,
Mr. Chair, and thank you so much to the organizing committee for the invitation to participate in the first international conference of the Oman Society of Nephrology and Transplantation. I'm deeply honored, and today we will present 3 clinical pathological cases. We hope you find these interesting. The main objective is really to show the importance of clinical pathological correlation in patient management, the importance of giving the relevant clinical information to the pathologist, and the impact a pathology report may have on patient management. Dr. Sajja, my colleague, a very experienced nephrologist in SQUH, is actually going to do most of the talking. I'll just be presenting the pathology findings. So without further ado, I give her the floor to take us through the first case.
Assalamu alaikum. Good afternoon, everybody, and thank you for the nice introduction. I will start with the clinical scenario. Let's start with the first. It is case-based interactive discussion, so hopefully you will interact with us. So let's start with the first case. So we have Mr. H.A. He's an 86-year-old Omani male with a background of hypertension on 2 medications. He is dyslipidemic on atorvastatin. He is functional status, limited mobility because of bilateral eye blindness, and he's fully dependent on his family. Admitted with the impression of community-acquired pneumonia versus aspiration pneumonia based on short history of upper respiratory tract infection symptoms with the history of repeated vomiting. So there is a query, also a history of aspiration. And this is his X-ray upon the admission. We can see that there is a clear infiltrate in the left side of the lung. So we got involved because the patient also during his admission, he got acute kidney injury versus acute kidney injury on the background of chronic kidney disease. And when we saw the patient, he is having generalized edema, like significant generalized edema with blood pressure in the lower side. And his urine dipstick is positive for albumin. There is no RBCs. Urine protein creatinine ratio is highly significant, 2 times of more than 1,500 to 1,600 milligram per millimole in our reference lab. The normal is less than 15. And his serum albumin is 13 gram with a 24-hour protein confirmed nephrotic range proteinuria. And his serum creatine on admission is around 200, while his baseline is 189, and the baseline GFR 70 ml per minute. This is in 2020. So further workup of this patient, because basically this is like in summary, he is elderly patient with abrupt onset of severe nephrotic syndrome. And it was to be workup further. And in this group, we have to go for autoimmune workup, and it was negative. Antiphospholipase A2 receptor was 1, which is normal, and complement was C3, C4 normal. There is chronic viral screen also all negative for HIV, hepatitis C, and hepatitis B. And of course, at this age, you have to rule out multiple myeloma, so SPAP done for him, which showed like a very faint band in the free Kappa light chain, which is doubtful significant. So, do you want further workup for this patient? What do you want next? Any thoughts? Before bone marrow?
Renal biopsy.
So, do you want to look to the kidney?
Yeah.
So we will go for imaging, okay, because this patient, we don't know his background. And we, of course, at this age, like we have to rule out secondary causes of membranous at least. So we have to go for further imaging. Even we did endoscopy, upper and lower scope. And we can see in the first slide here, you can see here, sorry. You can see in the first slide, in the left image, there is a normal sized kidney with increased echogenicity, and there is like a well-demarcated mass, heterogeneous mass, related to the right upper pole. And further imaging by MRI, there is the same mass, which is more this one. Sorry. Anyhow, we will start with biopsy for the sake of time. So, Dr. Marwa.
Actually, the patient had two biopsies, biopsy of the mass as well as biopsy of the background kidney, non-neoplastic kidney. So I hope, okay, so here we go. So begin with our own area of interest for today, which is the medical kidney. So we had these 4 cores of renal tissue, including both the cortex and medulla. Looking just generally to the background, there were definitely areas of fibrosis and atrophy, so it was not entirely a normal kidney. We had a total of 9 glomeruli, 4 of which were totally sclerosed, 1 was segmentally scarred, and there were 2 large arteries. Looking a bit closer, here's one glomerulus. Now remember, this patient is not diabetic. His glomerulus shows definite expansion of mesangial areas by matrix material, not so much of mesangial hypercellularity. Capillary loops are patent, some of them are a bit narrowed, and maybe a little scar in this area here. Looking closer, you can see this expansion of mesangium by this very homogeneous pink material. Going to the special stains, this is the PS stain. So if you compare the staining of the tubular basement membrane, for example, with the pink texture of the mesangium, you'd notice that it's sort of a pale pink color, very homogeneous in its appearance. And you can see that here as well. And we have also some thickening, segmental thickening of the capillary walls. The silver stain, hope that comes up next, so shows you that this material is non-argyrophilic or does not pick up the silver stain. Silver stain is black. So if this is silver positive, if it's collagen, it would have been silver positive. So it's not collagen. And I don't know if you would see it clearly enough here, there's this hint of fine hairs sort of on this membrane. These are not really spikes, but they are known as the Cox comb. We don't commonly use this term, but that's what they are known as. Name the stain. Name the stain. Congo red. Okay, so Congo red highlights this congophilic material, typically described in the literature as a salmon pink color. We see it in the glomeruli. We see it also in some of the blood vessels, and also there were some few flecks in the interstitium. Polarization highlights nice